Welcome everyone to this webinar today. This is a DIA special webinar because we are focusing on a topic that has received national attention, as you saw from our introduction video from President Obama, but also we're seeing a lot of activity in legislation. Today, I'm joined by three presenters. We have Dr. Ronald Kulich from Tufts University School of Dental Medicine, Dr. David Keith from Harvard School of Dental Medicine, and Dr. David DiNicenzo from Boston University Henry M. Goldman School of Dental Medicine. If you notice, all three of our presenters are from Massachusetts, and this was intentional because these schools have actually worked together and showed great leadership in addressing the opioid crisis, and we'll hear about that, of course, throughout this webinar. So again, we're pleased so much to have all of them join us, and thank you so much for being here. So to go over today's objectives, we have several things that we'd like to have you all walk away with today. There's three different areas. The first is we want you to understand what are the key events and statistics regarding the opioid epidemic, in specific to dentistry, but also nationwide and within the whole healthcare system. Second, we'd like to discuss the Massachusetts model. Again, the reason why we have all three schools represented from Massachusetts. And because what they were able to do with the Massachusetts model was bring attention and be a change agent to respond to the opioid abuse within their state and then also at the national level. Lastly, we want to identify the implications this has for your individual institutions, your dental programs, and of course the curriculum that you would set for your students and residents. So first, we will begin with our first area of our first objective, which will be presented by Dr. Kulich. Dr. Kulich, if you could tell us what's happening as far as the statistics and trends related to the opioid epidemic, that would be great.
Sure. I'm really delighted to talk about this. This is an interesting evolution. It actually, a number of folks around the country, including a number of individuals from our group, have been working on this issue in terms of risk stratification and assessment with regard to opiate risk. And a number of months ago, our particular university was approached, the dental school and Dr. Thomas were approached by the medical school, essentially asking for a review and sign-off of the medical education core competencies, basically a write-up presentation evolving from some of the governor's work with the state. We took a look at it, and basically the thought was, particularly from a dentistry standpoint, maybe we could do a little bit better job with this and make it more dental relevant. And I think we did with a really great working group we put together here. It's actually been interesting looking at some of the data. This is some of the background data. Their overdose deaths are really continuing. There's a dramatic increase in terms of writing opiates over a number of 10, 15 plus years. Actually, there's been a precipitous drop in the actual quantity of opiates being written by dentists, emergency rooms, and other particular subspecialists. But despite that drop, we're continuing with the deaths because individuals are switching over to heroin and other drugs, which have even a higher risk. So there's been a big issue in terms of going on with increasing deaths across the country. I also think that if you actually look at some of the data, it is not just overdose in terms of opioid deaths particularly, but other meds with regard to polypharmacy. 23,000 deaths related to prescription drug overdose, opioid painkillers, and almost 7,000 mixed with benzodiazepines. So I think it's been a real big issue when dentists see these patients. Often we just think about the risk associated with writing opiates, but we don't think about the whole issue of the multiple drugs that patients come in on, particularly benzodiazepines and other high-risk medications. So this is essentially how it happens. Individuals go to their primary care provider, maybe their dentist, medications go home with the patient, maybe for a third molar extraction, they get a large bottle of oxycodone or hydrocodone, and it goes to the medicine cabinet. And if you actually look at the data over a number of years, it gets shifted from the medicine cabinet off to the street. It's interesting, this diversion has been significant to the extent that we're even seeing realtors now being coached in terms of risk because individuals are going from open house to open house to open house, stealing from medicine cabinets, mostly from the elderly who may be moving out of their home. So it's been a big issue in terms of the extra drugs that are floating around and some of the risks associated with that. If we look a little bit further, right now you could reach into your pocket if you have any opiates or controlled substances. Probably within about a 5-block area, you could make an estimate about what they're worth on a street. And those involved in the drug industry illicitly are going online, and there's a market right now in terms of checking what these are worth at a given area. So there's an interesting market in these drugs that's right now pretty much readily available online in terms of how much it's out there. In fact, within the last couple of weeks, ProPublica has published all the Medicare data on providers who are writing controlled substances. And you can actually go and log on and look up your local dentist or primary care doc and see how likely it is you're going to get opiates from that particular provider. And as I mentioned recently on NPR, you can actually go shopping for a quote good dentist or a good surgeon or provider to see where you're most likely to get your opiates or benzodiazepines. So it's a complicated issue. It's a complicated issue that's sort of permeated all healthcare. It used to be that dentists were the top 3 or 4 prescribers of opiates, and again, I think there's been a precipitous drop in some of that. 85% of scripts had been written for hydrocodone and oxycodone, many for a number of weeks by dentistry. At one point, dentists were writing 8% of the opiates right behind PCPs and internists. Been a precipitous drop again in this area. So we've seen the past in terms of 1 to 1.5 billion doses of immediate release opioids each year from dentistry. However, you see this shift, but there probably has not been a shift in dentistry with respect to specific assessment of risk abuse when the patients come into the office. As I mentioned, here's some data in terms of Parrish's work, really a nice review and study. 2015, ER decrease in opioid writing, 9%, dentistry, a 6% drop. Some people say it's even higher than that, up to 20 or 30%, depending upon the study. And 3/4 of still, despite the fact there's been a drop in opioid writing, 3/4 of all dentists report that they do ask their patients about substance abuse, because the issue isn't just writing fewer scripts or smaller scripts. The issue is assessing patients for substance abuse risk with the follow-up, appropriate counseling and referral where possible. Having said that, it's a tough sell. It's a tough sell because again, from some of Parrish's data, 2/3 of dentists don't agree that such screening is compatible with their professional role. And that's where we could drill down and go into the dental schools and talk about the expansion of dentistry's role, particularly with regard to screening for substance use risk and kind of ability to counsel our patients and make appropriate referrals. There are a lot of special populations I think we hit in dentistry that often go unrecognized. Populations that are particularly hard hit by this opioid crisis and the crisis of other controlled substances. This is just another example, an area we've been working on in our school with regard to screening women of childbearing age. This is some of the data on neonatal abstinence syndrome increases over a period of time. Again, dentists often see these patients early on and are in a really unique position to do screening, some counseling and referral for substance abuse risk, in this case significantly assisting the patient and the infant. So dentistry could have a big impact here, and my colleagues will talk about this at some length in terms of the training focus. Prior experience and knowledge about substance use seems to be the strongest predictor of dentist inquiry about whether substance use, misuse is part of the role. So again, this is where the schools have a big focus, training effort, any efforts to focus on ability for students to do early screening and counseling and referral. That's the direction we're essentially moving in. So I just want to conclude by saying there's a lot of guidelines, and these are evolving very, very rapidly as new data comes out. David and Rick are going to talk at some length about what the different schools are doing and the direction we're trying to head with this. The take-home message is really fully assessing the patient, even if someone is not particularly focused on writing controlled substances. The idea of fully assessing the patients when substances are used, controlled substances, shorter scripts, looking at alternatives to opiates, and David will discuss some of that. But certainly the key is we still have to provide pain relief for our patients. So I'm going to turn it over to Dr. Keith, and he's going to talk a little bit about the detail on this.
Dr. Kulich, actually now might be a great time to actually get an idea of who's joined the webinar thus far. So first of all, thank you though for your presentation. It's quite startling to know how far this epidemic has permeated through healthcare and then also just our basic lives, especially when you mentioned the real estate aspect. So this would be a great time, like I said, to introduce everyone to the IDEA webinar. This is our special webinar on opioid abuse in the U.S. and the implications for dental education. I am your host, Dr. Evelyn Lucas-Perry, Director of Public Policy Research here at the American Dental Education Association, and we're also joined by our three presenters. You just heard from Dr. Ronald Kulich, from Tufts University School of Dental Medicine, and then later on we'll hear from Dr. David Keith from Harvard School of Dental Medicine and Dr. Richard DiNicenzo from Boston University Henry M. Goldman School of Dental Medicine. So Don, actually this would also be a great time to, before we continue with our discussion, to get an idea of who's on the call. So I'd like to turn it over to you.
All right, thank you, Dr. Lucas-Perry. So at this time, we are going to put a polling question up, and we want to thank you in advance for your participation in our attendance polling today. We would like to know how many people are listening in at your location, and we'd like you to click the button that most accurately represents the number of attendees at your site, whether it be 1, 2, 3, 4, 5, up to 10 or more. Again, we would like to know how many people are listening in at your location. Allow a little time here for folks to record their response, and we ask that you please do so as quickly as possible so that we can get rolling once again with the presentation. Again, how many people are listening in at your location? The votes are still coming in here. We'll allow a little additional time for folks to record their response. And the voting is beginning to slow here. We'll wait another moment or two. And at this time, we will close that poll. And once again, we thank our audience for participation in today's attendance polling.
Thank you. Thank you, Don. Appreciate that. We have great attendance today. So let's turn it over to our next speaker, Dr. David Keith. Dr. Keith, can you tell us a little bit more about the idea of the Massachusetts model and how these schools how you and the other two schools in Massachusetts have worked together?
Yes, thank you. Dr. Kulich has outlined the facts about the national opioid epidemic. The situation in the Commonwealth of Massachusetts has reached crisis level. This graph, which was published just a few days ago, demonstrates the continuing rise in unintentional opioid deaths in recent years, despite all the attention that has been paid to this issue. These figures do not separate out the different types of opioids, but is one index being used for monitoring prescription drug misuse. The fact is that 4 out of 5 heroin abusers start with prescription opioids. These figures amount to 3 deaths a day in our state, but represent just the tip of the iceberg. Data shows that all regions, cities, and towns in Massachusetts are involved, and all educational and socio-economic classes are affected. For every opioid-related death, there are 15 abuse treatment admissions, 26 emergency room visits, 115 individuals who are abusers or who are dependent, and a staggering 733 persons who are using opioids for non-medical purposes, not to mention the number of emergency calls ambulance rides, and Narcan administrations that are associated with opioid overdoses. With this information, the Baker administration has taken the situation very seriously and has developed a user-friendly website for lay and professional communities and has undertaken a broad range of initiatives. The governor has been personally involved in this initiative and has included dentists as prescribers in all his statements as a result of experiences that he and his family have had. In addressing the prescribers' responsibilities, the first step that the state took was to bring together the deans of the 4 Massachusetts medical schools. Their working group document was published in November of 2015. Around that time, the state reached out to the 3 Boston dental schools and asked them to prepare a similar document. In our discussions, we came to the conclusion that we needed to address the issues in a way that made sense for dental education and the practice of dentistry, which is different from medicine in several significant ways. The vast majority of dentists work in solo practices, while over the past several years, physicians have joined together in groups. By nature of the work that we do, dentists are more familiar with acute pain and have limited experience of chronic pain. While medical group practice allows for integration, interdisciplinary collaboration, and sharing of best practices, dentists tend to be more isolated from their medical colleagues. A further factor is that orofacial pain is taught in many different ways in dental schools across the country, and few resources are available for consultation or management. With this in mind, the Dental Education Working Group met with the governor earlier this year. The recommendations were introduced by the governor, the Secretary of State for Human Services, and the Commissioner for Public Health at a press conference at the State House. This initiative would not have been possible without the leadership from the state. An example of this relates to the prescription monitoring program. In October of this year, Massachusetts prescribers will be required by law to review this database for every patient to whom they are prescribing opioids for the first time. Oral and maxillofacial surgery and general practice residents working in hospitals can access this data using the designated institutional officer's password. Other dental residents and faculties who do not have full state dental licenses cannot access this data. But the working group are collaborating with the Department of Public Health to rectify this situation. We are also very fortunate to have the support of the Massachusetts Dental Society, who have, among other activities, published related articles in their journal, committed time at the Yankee Dental Congress in 2017, and numerous CE lectures throughout the year to this topic. They are in discussion with the dental schools to develop an online continuing education program relevant to dentistry to fulfill the 2-hour mandatory training that are required every 2 years for licensing. The medical school initiative was moved forward by a group of medical students who perceived a deficiency in their medical education concerning opioid use. Subsequent to a meeting of the medical and dental task forces which they attended, they incorporated dental students into their group. Dr. D'Innocenzo will now discuss the details of the individual dental school initiatives.
Thank you, Dr. Keith. That was quite interesting, especially hearing from both ends, top-down and also the groundswell of how you had a lot of action within your state legislative body, but also how you had the students take a lot of initiative related to addressing the opioid epidemic. So you're right. Right now would be a great time to have Dr. DiNicenzo share with us these implications specifically for dental schools, but also how you can incorporate them into the dental curriculum.
Thank you, Dr. Lucas Perry, and good afternoon, everyone. I appreciate the opportunity today to present the implications for dental education and curriculum in regards to prescription drug misuse. As Dr. Keith has already presented, the dental education core competencies as the recommendations from the Governor's Dental Education Working Group on prescription drug misuse. What I wanted to cover was that these competencies were developed with the idea in which a patient with pain would require a prescription for an analgesic medication in which potential misuse can occur. The goal is to provide future prescribers with the knowledge and skills to competently prevent prescription medication misuse and to serve as a bridge between student education and residency training. The core competencies are divided into primary, secondary, and tertiary prevention domains. The primary domain relates to the evaluation of the patient's pain and developing an appropriate differential diagnosis. It also relates to the evaluation of the patient's risk for substance use disorder and to identify pharmacological, whether opioid or non-opioid, and non-pharmacological treatment for acute or chronic pain, along with the risk and benefits of the treatment provided. And finally, the domain relates to the proper storing, while in use, and disposal of any unused medications. Most of these criteria are already covered in the dental curriculum today and may only require a slight modification to the present curriculum. The secondary domain relates to the ability to appropriately refer patients for consultation and collaboration with their primary care physician or care providers. It also provides for the practice of patient-centered, evidence-based pain management, safe prescribing, and the ability to recognize patients displaying signs of aberrant prescription behaviors. Presently, through their dental education, the students are instructed how to properly request a medical consultation when required for their patients prior to undergoing dental treatment. This usually involves requesting information in regards to clarifying the patient's past medical history, medications, and updated lab results, along with confirming that the patient is medically optimized to undergo the procedure. Perioperative recommendations may also be requested. The same principles are used when obtaining a consult in regards to the proper pain management of these patients who have completed recovery or are undergoing treatment for substance misuse. In regards to this domain, the possibility of needing minor to moderate modifications to curriculum may be required. The tertiary domain relates to the use of screening instruments to determine the at-risk patient, eliminating the stigma associated with substance misuse, viewing it more as a disease, and develop an interprofessional education and engage in collaborative training. Now, this may be where the most effort may be required to put forth in regards to curriculum development and or adjustment. The core competencies that were developed in Massachusetts allows the schools to tailor their competencies to their own curriculum development. Now, there may be challenges with the incorporation of these competencies into the curriculum. Some of these could relate to include the time constraints in already robust curriculum, along with financial and manpower limitations. Although in the early stages, I'll present some of what is occurring or planned to be implemented at the 3 dental schools in Boston. In my opinion, this is a fluid process and changes will be made as is required. Even though the curriculum at the schools may differ, some components are shared by all, such as intra- and interprofessional education, implementation of a clinical training component, the instruction and use of the prescription drug monitoring program, and the possible use of continuing education courses to help in the training of undergraduate and postgraduate students. The next set of slides that I'm going to present will have a lot of information included in them. I will only cover some of the points listed and elaborate on these points. The Harvard School of Dental Medicine is the lead institution in the Boston-based NIH Pain Consortium Centers of Excellence in Pain and Education. The Harvard School of Dental Medicine and Harvard Medical Schools are introducing a new combined curriculum. As both the dental and medical schools in Massachusetts accepted the core competencies in regards to opioid misuse, this will be advantageous to introducing these competencies into the new curriculum. The new curriculum will also include such teaching techniques as the flipped classroom, problem-based learning, traditional lectures, and hands-on experience to introduce the foundational building blocks required to study medicine. The longitudinal practice of medicine course will offer the students the opportunity to learn clinical medicine through a multifaceted approach which will be guided by expert faculty in both outpatient and inpatient settings. During the first year of the combined curriculum, the students will rotate in the dental school clinics in which they will work with physicians and dentists in the evaluation of patients and screening for substance misuse, pain management, and understand the prescription drug monitoring program along with the data that can be obtained from it. Advanced graduate education instruction through core curriculum, primarily the pharmacology course, will provide for the evaluation of patients, screening for substance abuse, pain management, and the prescription monitoring program. Tufts University established an interprofessional working group made up of faculty from dentistry, oral surgery, internal medicine, psychology, psychiatry, basic sciences, public health, and biostatistics. The Rubin Group was established to further incorporate contents of the recommended curriculum into the undergraduate and graduate dental programs. It will also develop strategies to integrate the curriculum into the clinical training experience with measurement of objective outcomes. There will be implementation of the Massachusetts Prescription Monitoring Plan, and a goal of the school is to increase student attendance at postgraduate continuing education, interprofessional training directed at substance using, screening, and pain management. Tufts presently offers approximately 15 hours of this CE content, and selected programs had as much as a 30% student attendees. And finally, along with the present research that is being performed, student and faculty research in risk screening and pain management will be promoted, with increasing mentoring by current Tufts faculty and formal collaborative effort with pain and addiction specialists outside of the school. At the Boston University Henry M. Goldman School of Dental Medicine, they're presently using the screening, brief intervention, and referral to treatment model, the SBIRT. They are presently in collaboration with the Boston University School of Medicine through the Boston University Evidence-Based SBIRT Training. This is being funded by a recently awarded SAMHSA grant. The goal is to enhance existing substance use misuse curriculum in areas of behavioral health, patient communication, and interprofessional team-based practice in an integrated, multidisciplinary, collaborative environment. The curriculum has also been updated, and an incorporation of recommended contents in didactic courses and clinical experience has begun. An online continuing education program regarding the evaluation and treatment of acute dental pain, which includes evaluation, proper medication treatment, screening for substance misuse, and aberrant behavior, has been integrated into the curriculum. With the assessment of the competencies, we want to evaluate the students for baseline and post-implementation measurements. A performance-based evaluation in which utilizing a clinical setting or simulation, which could include using standardized patients and or technology-enhanced simulation, would be appropriate for assessing the student. So, to summarize, the core competencies should be tailored to the school's own curriculum development. Such differences as class size and teaching protocols will influence how one adapts or adopts the competencies to be incorporated into their own school curriculum. Thank you.
Thank you so much, Dr. DiNicenzo. That was pretty interesting how you all have incorporated the Massachusetts model into each of your individual institutions. We have a couple questions that we've received from the audience, and I'll direct this first one to Dr. Kulich, and it's related to the assessment. We spoke about that most dentists are doing assessments within their practice. Can you kind of tell us what those assessment tools are, and if it's a questionnaire?
Sure. I think much work has been done in the medical area in terms of screening instruments, short screening instruments for risk for substance abuse or misuse with controlled substances. And in fact, we at Tufts have one of my colleagues, Dr. Finkelman, has an NIH grant looking at improvement in terms of some of the opioid risk screening tools. The trouble with these tools are it's a simple answer, and that's really not where we want to go to basically flood the field with a series of quick questionnaires where patients could be screened and essentially, perhaps in some cases, deprived of opiates or screened out as at-risk patients. The focus probably needs to be on the clinical assessment of the patient, using screening tools as an adjunct, and teaching the undergraduate dental students certain particular assessment techniques. So we do an adequate substance use risk screening. Dentists become comfortable with counseling the patient and referral, and particularly collaborative efforts with other professionals. In dental schools, I think a take-home message too is the faculty. There really needs to be interprofessional faculty. We've been fortunate to have psychologists and psychiatrists on staff, but the idea of training in interviewing is the key issue. So it's not as simple as a questionnaire.
Great, thank you for that. And you've mentioned, well, in your answer, interprofessionalism and working with other healthcare professions. And Dr. DiNicenzo, you mentioned that as well as a part of developing this curriculum. Can you touch upon how you've really worked with some of the other schools and maybe what challenges that you face and what has worked out well?
So with the interprofessional, so we're talking about like with other forms of professionals such as medical colleagues, pharmacology, nursing, etc. We spent a lot of time with the medical school where we're working on this expert program. And by working through them, we're going through the training program, the evaluation, and brief intervention and brief treatment, basically what Dr. Kulich has spoken about. Also, another part of interprofessional would be as we go through the referral portion, that would go along with how do you set up the appropriate consultation or referral to the other medical professions in regards to medical clearances or referring them out for treatment as should be required for a substance abuse or somebody that requires or wants to follow up with substance abuse.
So this is David Keith. I wonder if I could just butt in here. At the Harvard Dental School, the students spend the first 2 years with their medical colleagues and have the same educational offerings. The program that my colleague Dr. Schaefer is heading involves medical students, dental students, nursing students, and pharmacy students all coming together and discussing a case which has relevance to each of their specialties. So I think under those circumstances, the dental students become comfortable with discussing these issues with medical colleagues, nursing colleagues, and pharmacists.
Thank you so much. That's quite interesting how you all were able to work with the other schools. We had another question, and it related to research. And really, if you all are engaging in, I know you mentioned that some of the schools have received grants. So are you involved or engaged in any upstream intervention protocol research? And if so, how is research with this rollout of the new curriculum being considered? And that was to any of you, any of our presenters.
I think the critical, this is Ron Kulich here, the critical issue is not just, again, I think both of my colleagues mentioned this on a number of occasions. The issue is not just evaluating content, but really evaluating outcome, performance outcome with the students. And going forward, that's what we're all looking at. So we have objective outcomes. So several projects are underway. We have a couple projects with the IRB review board looking at outcomes in terms of use of prescription monitoring program among faculty and students. So it's we need to look at objective outcomes for this. So that's certainly our intent.
Yes, David Keith, I think this is very early days. The press conference and the rollout of this initiative occurred a couple of months ago, but certainly once we have the basic building blocks in place, I think there's a lot of opportunity to do research and outcome research. Thank you.
Thank you. Another thing is, Dr. Keith, this might be best since you talked about the progress of how you all came up with the Massachusetts model. How did you look at any other states, what they were doing and what guidelines they had set forth?
No, we didn't, but I think we'd be very interested in hearing from the audience if they have any information that might help us all.
Yeah, we received a question from someone asking if you all reviewed Pennsylvania's guidelines, and so I was just interested.
Yes, actually, that's a good point. I did review that, but I don't think it was used in our discussions.
Okay, great.
Yeah.
But
my comment, this is Ron Kulich again. In looking at the guidelines, much of them have been for medicine, and as everybody probably is aware, the CDC guideline just came out. Again, heavily focused on chronic opioid therapy, although addressing acute use as well. A lot of the medical guidelines are actually quite good. A lot of the states are adapting them, but the dentistry hopefully will be close behind.
Thank you. And another question we got was pretty interesting. We touched earlier about interprofessional education, so that's, our dental schools working with pharmacy, medicine, nursing, but also how can these guidelines be applied to our dental hygiene colleagues? And maybe Dr. DiNicenzo, you might want to take a stab at this.
So, from the dental hygienist, from the dental hygiene perspective, one of the things you could probably bring through that would be like a screening type of evaluation process. And if you're looking towards like a core competency, that's what's been accepted, like with what we have through dentistry, there's also things that are going to be rolled out. It's not just going to be like medicine dentistry, but other programs that can prescribe the opioid medications do become part of this, the pharmacist and physician's assistants and things of that nature. That's what we're looking at. So if you're trying to come up with a program with core competencies, it may be more along the screening aspect of the patients and the referral of the patients and getting that information together. I don't know if that answers your question, and I don't know if David or Ron has any other.
Yes, this is David Keith. The state was looking at continuing this process by involving the auxiliary services such as dental hygiene, nurse practitioners, physician's assistants. I'm not sure how far they've got with that, but that was one idea that they had. And it was interesting. I was talking to a group out in the middle part of the state. It was a constituent dental society of the Massachusetts Dental Society, and the program had been initiated by the pharmacy students. They had some interest and concerns about dental prescribing habits in their area of the state, and they persuaded the Dental Society to put on a pain management program. So I think there is a lot of opportunity for us to involve not only dental hygienists but dental assistants.
David, now even in our state, dental hygienists through the delegate model can have access to the prescription monitoring program data as well. So, I mean, there are a lot of opportunities for folks in the office here. Also, I mean, as you guys all know, the dental hygienists often have a very close relationship with patients, outstanding clinical skills, and we just completed a brief paper on hygienists acting as the substance risk screeners in the practice, and I think that there's an impressive role for that group with regard to the initial screening and counseling the patient.
You just piggybacked on something, and there's one of our questions that was asked, or how should our providers, our dentists and our dental hygienists, how should they be discussing this with patients? How can they, without accusing them, I guess, of being addicts? What is the appropriate way, or what type of training have you all considered when discussing this with patients?
Well, This is David Keith. I'm an oral surgeon, and so I do prescribe opioids for my surgical patients. And I usually talk about the risks and the benefits, and if there are any other alternatives, and take that opportunity to talk about storage and disposal, especially if they're wisdom teeth patients. They're going to be young, and those individuals are most at risk for medication misuse. So I think when you're prescribing medications, there is an opportunity. Some of us who are older may be a little uncomfortable with that discussion, but at least in Massachusetts, hardly a day goes by that we don't hear something about the opioid abuse crisis in the media in one way or another. So I think the time is right for those conversations to take place. And I think there's also been a shift in the language that we use. We're talking about opioid misuse, not necessarily abuse, which is still part of the problem. So part of the objectives, both in the medical school curriculum and in the dental school curriculum, was to teach people not to stigmatize individuals who may be using opioid medications for legitimate use.
David, I'm going to just add to what you said. Everybody's uncomfortable with some of this discussion. So this is not unique to dentistry. I mean, whether it's a psychologist or a surgeon or an internist, it's a discussion that's important with our patients. And I think that's, again, the area that dental school students could really excel in. There's some work in our institution and elsewhere going on with motivational interviewing, where essentially practice in interviewing the patient, discussing some of these sensitive subject matters. It hopefully gets to be second nature, and the data seems to show that patients appreciate it as opposed to feeling offended by it. The dentist may be one of the first healthcare providers to actually discuss the issue of risk, and is a good conduit for referral.
Great, thank you. It's good to know that all of these conversations are being had and, of course, are incorporated and being strengthened within the curriculum. Right now, I think most of our questions have come, you've answered most of them. And so is there anything that you all would like to add? I'll turn it over to Dr. Kulich before we close out. Is there anything else you'd like to add to the conversation?
This is David Keith. I'm looking at the chat page, and is that going to be available? There are some useful references there that I'd like to follow up on.
Oh, you know, that's a great idea, because what we've had now is we've actually had great discussion online with our participants. So what we'll do is we'll actually copy all of the links that everyone is sending. We'll just copy those links and include them in a final slide that will be posted during the webinar. So again, the webinar along with the audio will be posted to our website a week from today. And your registration, you'll receive a link via email to get to that website.
Great.
Great.
Hi, this is Rick DiNacenzo. Just a few other things as we're talking about
Sure.
bringing it into the curriculum, and I'll be very quick on this. I saw one of the questions up there was, besides time, what are some of the other things? I had made mention that financial considerations are always a problem. If you're going to go through simulation, whether you're going to have professional patients or whether you're going to use technology with that, that's going to cost money. So there's always concerns with that. So some of the things that we're thinking about is doing training the trainers so that we can use the faculty that we already have. And that could be a manpower limitation. So those are some of the other things that I see could be issues as you go forward, but you may be able to get around them. So it's basically some cost and manpower is also a big issue besides time. And I do want to reiterate what Dr. Keith had said about, with your screening of the patients, they may not be a substance abuser, but they may be set up to become one. I think we need to do a good job on screening and then counseling those patients with the use of narcotics, and the limit of the narcotics is only needed for the treatment of the acute pain situation that they are going through. And that's it.
Great. Anyone else have anything to add? Because otherwise we're almost approaching our time to end our webinar today. Okay. Without further ado, I am going to thank our presenters. Again, thank you so much for sharing your expertise and, of course, being a part of the discussion. We had a great discussion today, both with our presenters and also online amongst our attendees.
This concludes today's event. Thank you, and have a great day.